So, chapter 12's Media Under the Microscope talks about an article where mice gut bacteria were actually looked at in New York City to see the relationship between the gut bacteria in the mice and humans. And it's kind of an interesting article in the fact that the mice actually harbor a lot of antimicrobial resistant organisms that we can see in humans. So, what are the principles of antimicrobial therapy? The goal of antimicrobial chemotherapy is to administer a drug to an infected person that will destroy the infective agent without harming the host themselves. And I will say this, the perfect drug does not exist. It just isn't out there. There is no such thing as the perfect medication or the magic pill. Now, there are several characteristics of an ideal antimicrobial drug. First of all, we would like for it to be selectively toxic, and this is a key factor in choosing antimicrobial drugs. Selective toxicity to the microbe, but is non-toxic to the host. Microbiocidal rather than microbiostatic. Relatively soluble and functions even when highly diluted in body fluids. Remains potent long enough to act and is not broken down or excreted prematurely, doesn't lead to the development of antimicrobial resistance, will complement or assist the body's activities in immunity, will remain active in the tissue and body fluids, is readily deliverable to the site of infection, and again, is reasonably cost effective and does not disrupt the host health by causing adverse reactions such as allergies or predisposing the host to other infections. Now, a chemotherapeutic drug. Today, we oftentimes think of chemotherapeutic drugs as for cancer only, but really the true definition of chemotherapy is when we use any chemical in the treatment, relief, or prophylaxis or prevention of a disease. And prophylaxis is the use of a drug to prevent imminent infection of a person at risk. So, for example, we could actually say vaccines are prophylactic in their function. Antimicrobial chemotherapy is using an antimicrobial drug in order to control a microbial infection. Antimicrobials is an all-inclusive term for any antimicrobial drug, regardless of what type of microorganism it targets. So it would be our antibiotics, our antifungals, and our antivirals. Antibiotics are substances produced usually by natural metabolic processes of one organism or synthetically created by scientists that can inhibit or destroy bacteria and some of the fungi. Semi-synthetic drugs are drugs that are chemically modified in the laboratory from the natural source after being isolated, and in this way oftentimes gives them more effectiveness. And then synthetic drugs are drugs produced entirely by chemical reactions in a laboratory. Narrow spectrum drugs are those that are effective against only a limited array of microbial types. So, for example, an antibiotic may only work on gram-positive bacteria, whereas broad spectrum, this is where now the antimicrobial will be effective against a much wider variety of microbial types. For example, an antibiotic may be effective against both gram-positive and gram-negatives. Now, where did our antibiotics actually come from? Well, antibiotics usually are metabolic products of other bacteria and or fungi. The first commercially available antibiotic was penicillin, and it actually is produced by the Penicillium mold. Why do they produce these products? Well, it's basically chemical warfare out there amongst the microbes. And so one organism will produce something that inhibits the growth of others in the same habitat, and this reduces competition for nutrients and space. This is basically survival of the fittest. And the selective advantage of one over the other has allowed the genes for antibiotic production to actually be preserved in evolution. Now, new drugs are oftentimes created by chemically altering the structure of naturally occurring antibiotics to make them more effective, and these are known as the semi-synthetic drugs. However, there are some drugs which natural compounds either cannot be obtained without the destruction of the habitat of the organism that produces them, or there is just simply no such drug or chemical produced out there. And these are the synthetic drugs. So they are created in the laboratory to mimic the action of some of the natural compounds. So in the penicillin class of antibiotics, we have the natural penicillins, the semi-synthetics, and the synthetic penicillins. In order to start treatment, really we need to know three things about the infection. One, we'd like to know the identity of the microorganism causing the infection. Is it a gram-positive? Is it a gram-negative? Is it an acid-fast organism? But really, we'd like to basically just identify this is a Staphylococcus aureus infection. The degree of the microorganism's susceptibility or sensitivity to the various drugs. And so we talk about doing culture to identify and sensitivity testing to identify what drugs may be effective against this particular microorganism. And we really need to look at our patient. We need to know the overall medical condition of the patient before we start treatment. Because are these drugs without side effects? Well, no, and they can have very serious side effects in certain patients. Identification of the organism that's causing the infection should be attempted as soon as possible. This doesn't always happen to take place, however. It ought to be done before any antimicrobial drug is given. However, because some of these organisms take a while to grow, at least up to 24 to 48 hours, and sometimes more longer than that, then we may actually have to start with an antibiotic based upon our best guess, and then change once we have identified the organism. We can identify infectious agents by direct examination of body fluids, sputum, or stools, and of course we can actually then do culture and sensitivities. Now, one of the ways that we test for drug susceptibility is a technique called the Kirby-Bauer plate. This is a special auger called the Mitten-Heuler auger, where the surface of a fairly large auger plate is spread with a lawn of the test bacterium. In other words, we're not going to streak for isolation or streak for growth. We're going to just cover this plate in the bacterium. Then small discs that are impregnated with pre-measured amounts of antibiotics are dispensed onto the bacterial lawn on the surface of the plate. What we are looking for then is what's known as the zone of inhibition. As the drug leaches from the small disc into the media, if it is effective against this bacterium, it will actually kill it and cause a clearing of the bacterial lawn. We can then measure this zone of inhibition and compare it with the standard for each drug to determine if the organism is sensitive, intermediate, or resistant with this antibiotic. Antibiograms are profiles of antimicrobial sensitivities, and oftentimes facilities will have antibiograms that have some of the common infections that they see in their facility tested for with these different antibiotics so that they know when they see a staph infection, they have these drugs that they may choose from that the organism is sensitive to. So this is what a Kirby-Bauer plate looks like. When we inoculate the plate, we just simply absolutely cover this plate with our inoculating tool, be it a swab or a loop, and we create a complete lawn. So bacteria is spread over the entire surface. Then these discs impregnated with the different antibiotics are dropped onto the surface and we incubate the plate. Each of the discs will have a 2 or 3 letter identification for what drug is impregnated and the amount. So for example, GN is gentamicin and the 10 stands for 10 grams. Oftentimes, these are actually in micrograms as well. Then what we're looking for again is that zone of clearance or that zone of inhibition. And we're going to measure the diameter of the zone of inhibition. So for this particular antibiotic, we would measure from here to here, and then we're going to compare it to a standard chart for that particular drug. So let's look at an example of a Kirby-Bauer plate. So for example, if we were to use the drug bacitracin in one of these discs, and we measured the zone of inhibition in millimeters. If the zone was greater than 13 millimeters, it means that the organism is susceptible to bacitracin. But if the zone was less than 8, doesn't have to be 0, but less than 8, then it is resistant. So let's take a look at an example. So we have a Staphylococcus Kirby-Bauer plate. With bacitracin, you'll notice that the zone of inhibition measured 15 millimeters. 15 millimeters is greater than 13, therefore staph is actually susceptible to bacitracin. But let's go down here to penicillin G. Penicillin G, the zone of inhibition has to be greater than 29. If it's less than 20, we know it's resistant. We measure it at 10 millimeters, so that's less than 20. That means the Staph aureus is resistant to penicillin G. If we look at erythromycin, less than or greater than 18 we're susceptible, less than 13 we're resistant, but we measure at 15 millimeters. Well, that's right in between. It's greater than 13, but not greater than 18. So we actually say that erythromycin then is an intermediate drug for susceptibility. If nothing else worked, if everybody else was resistant and I had one intermediate drug, then that would be the drug that I would choose simply because I might get at least some effect. But in this case, I have several drugs that this staph is susceptible to, and probably my best choice would either be tetracycline or chloramphenicol, which I'll say, chloramphenicol is not an antibiotic used in humans because it has the rare effect of actually killing the bone marrow permanently. So it's not an antibiotic used in humans at all, because in 1 out of every 30 to 40,000, they wind up with what we call a non-regenerative aplastic anemia, and the bone marrow is basically dead from that point on. And we don't know what that 1 in 30 to 40,000 person will be, and so it's just not simply used in human medicine. Now, an alternative to the Kirby-Bauer plate is known as the echelon test or the E-test. And this is actually kind of the same thing as the impregnated discs, except in this case what we find as we move up the E-stick, we actually get increasing amounts of the antibiotic. And so what we're looking for is, again, a zone of inhibition. And in this case, what we also can figure out is the approximate lowest level we can use. So the very last point where I no longer see growth is at about 1.2 micrograms of this particular antibiotic, whatever it is. And so I can then, based upon that, figure out a dose. Now, would 256 micrograms work? Well, yeah, pretty good. The only problem is maybe this is toxic, whereas this might not be as toxic. And we'll talk a little bit about that a little later. Now, when I actually utilize antimicrobials, I have actually what's known as a drug formulary. And that drug formulary actually gives me information about the drug, what it works against, and it typically gives me a range for therapeutic dosing. Well, how did we actually determine these therapeutic doses? Well, two things go into that. And one of the things that we'll see is tube dilution testing. This is actually another way we can test antimicrobials against the bacteria. What we're looking for in the tube dilution test is the minimum inhibitory concentration, or what's known as the MIC. This is the smallest concentration of the drug or the highest dilution that visibly inhibits growth within dilution tubes. This is useful in determining the smallest effective dose of a drug. So if I have a drug that its therapeutic range is 2.5 milligrams per kilogram body weight to 5 milligrams per kilogram body weight, that 2.5 is the minimum inhibitory concentration. This provides then a comparative index against other antimicrobials. In clinical laboratories, these tube dilution tests are now actually performed by automated machinery, and we don't have to go through all of the dilution steps and the reading of the tubes. So historically, this is what we would do. We would have a negative control where basically no drug was added to the organisms. And what we saw was that we would put in a controlled number of test microbes into this, but no antibiotics, and so we would have plenty of growth. And then what we do is we would take that same concentration in each one of these tubes of the bacterium. Then what we would see is we would put in increasing amounts of the drug as we moved up the tubes. So we have 0.2 micrograms per milliliter in the first tube, 0.4, 0.8, and you'll notice we're basically doubling, or if we're going the other way, we're decreasing by half. And so where we no longer see visible growth is out here at 6.4 micrograms per milliliter, and so that would be the minimum inhibitory concentration of this drug. And then by using a mathematical equation, we can convert that into a minimum inhibitory concentration of dosage. Now these are actually done usually in microwells, and so we can actually use drugs, and what we'll see is that the blue indicates that there is no growth. And so each one of these drugs then is listed at its point of lowest concentration. So amphotericin B here, the lowest concentration was 0.125 micrograms per milliliter. Whereas this antibiotic goes all the way out to 256 micrograms per milliliter before we see no growth. And this one, we still put it at 0.125 micrograms per milliliter, even though it isn't completely blue, but it's not completely pink. And so we see inhibition at that point. Now, the results of the antimicrobial sensitivity is a guide for the physician's choice of a suitable antimicrobial. If treatment fails, there are several reasons why the failure actually occurred. It could be the inability of the drug to diffuse into the place where the infection is found. Some drugs simply can't get into certain areas of the body. For example, not very many antibiotics will cross the blood-brain barrier and actually enter into the brain tissue. Joints are also a protected area, and because the skin is actually not vascularized, it's very hard sometimes to get drugs to diffuse into the areas of the skin. Resistant microbes in the infection that didn't make it into the sample when collected for testing may also be a reason treatment fails. And it could be, and oftentimes is, that this is a mixed infection, that some of the organisms in the infection are actually resistant to the drug that we choose. The therapeutic index is the ratio of the dose of the drug that is toxic to humans to its minimum effective or therapeutic dose. The closer these two figures are to each other, in other words, the smaller the ratio, the greater potential for a toxic drug reaction. So, a therapeutic index of 1.1 is a much riskier choice of drug than one that has a therapeutic index of 10. This means that the minimum inhibitory concentration of the drug is actually 10 times less than when we would see a toxic effect. Whereas if we're at 1.1, that means basically we don't have a very wide area between the MIC and the therapeutic index, and so we don't have a very wide dose range that we could utilize without seeing toxic effects. So where did that 5 milligrams per kilogram come from? Well, that 5 milligrams per kilogram is based upon the therapeutic index of my drug. When drugs have similar mix, the drug with the highest TI then has the widest margin of safety. The patient has to be considered as well. Are there any pre-existing medical conditions that would influence the activity of the drug or the response of the patient? In other words, would they have a history of allergies to a certain class of drug? Do they have underlying liver or kidney disease? And this is important because most of our antimicrobials are either broken down or excreted through the liver and or kidney. Also, age plays a role. Infants, elderly, and pregnant women require special precautions. In infants and elderly, again, oftentimes liver or kidneys are not working perfectly, or simply that their immune system is not working well. And certainly with pregnant women, we have to be careful because of the growing embryo or fetus. So even with all of the information that's available to us, the final choice of drug is not always easy nor straightforward. So can you list and describe 4 characteristics of an ideal antimicrobial drug? True or false? Cephalosporins have all the characteristics of an ideal antimicrobial drug. And you may be able to answer this one a little later in the chapter. The what test shows antimicrobial susceptibility using large agar plates with Mittenhuler agar, a bacterial lawn, and antibiotic-infused discs. True or false, an antibiotic with a therapeutic index of 4 is less toxic than one with a therapeutic index of 40. And again, true or false, once antimicrobial susceptibility is established, choosing the right antibiotic is actually very easy. So again, really the idea of the use of antibiotics is going to be this idea or concept of selective toxicity. Antimicrobial drugs should kill or inhibit the microbial cell without simultaneously damaging host cells. And in some cases, this is easier than in others. The best drugs in current use block the actions or synthesis of molecules in microorganisms, but not within the host cell. Drugs with excellent selective toxicity would be things like penicillin. What penicillins do is block the synthesis of peptidoglycan in the cell walls of bacteria. Since animal cells do not have a peptidoglycan cell wall or even a cell wall, penicillins do nothing against these host cells. Drugs most toxic to human cells, however, are going to be those drugs that act upon a structure that is common to both the infectious agent and the host cell. So in other words, if I have a drug that's affecting the ribosome, it may actually affect the ribosomes within the host cell as well. As the characteristic of the infectious agent becomes more similar to that of the host, selective toxicity becomes more difficult. Think about this. Fungal cells are also eukaryotic cells. So drugs that affect fungus may also affect human host cells. Metabolic targets, again, of chemotherapeutic agent, and again, I can't say this enough. We inhibit cell wall synthesis or break down the cell wall. We interfere with the cell membrane structure or function. We inhibit protein synthesis, and that includes both the inhibition of nucleic acids of DNA and RNA in their structure and function. We can inhibit the ribosomal structure or function, stopping translation. And we inhibit the metabolic function, and primarily in bacteria, we are going to inhibit a folic acid synthesis pathway. So here's the picture. So let's start with the cell wall. And the cell wall inhibitors, again, either block synthesis of peptidoglycan or they block the repair or tear the wall down. And this includes penicillins, the cephalosporins, the carbapenemines, vancomycin, bacitracin, fosfomycin, and isoniazid. Cell membrane disruption is usually going to cause loss of the selective permeability of the cell membrane. And the polymyxins and daptomycin are two of the main antibiotics that affect the cell membrane. Of those drugs that affect DNA and RNA directly, the quinolones or fluoroquinolones actually inhibit replication and transcription. The way they do this is they actually inhibit DNA gyrase or topoisomerase that unwinds the supercoiling ahead of the replication fork. If we don't unwind the supercoiling of the double helix, we cannot actually split the DNA for either DNA synthesis or transcription. Rifampin is an antibiotic that actually inhibits RNA polymerase, and so therefore we cannot translate the DNA gene into the messenger RNA. Now there are several other drugs over here that inhibit protein synthesis by acting somewhere on the ribosomes. If the 50S subunit of the 70S ribosome is affected, it's erythromycin, clindamycin, and a couple of other ones. If the site of action is on the 30S subunit, the aminoglycosides, the tetracyclines, and the glycyclocyclines are the three big ones that affect the 30S subunit. Linezolid actually blocks the initiation of protein synthesis by blocking the ability of the 30S and 50S subunit to come together to form the complete ribosome. And then the fourth area is we block these metabolic pathways, and again, the main one that we're blocking in bacteria is folic acid synthesis. The sulfonamides and trimethoprim are the two main drugs that block folic acid synthesis in bacteria. So, true or false, an antibiotic that acts on a bacterial cell wall will have no effect on a human cell. An antibiotic that acts on the bacterial ribosome will have no effect on the human cell. And this one's kind of a tricky one, so you may have to think about it for a minute. So let's look at the major antimicrobial drug groups. Now, I'm not asking you to memorize all of the drugs. If you want to do that, go take pharmacology. But we're going to look at the major groups of drugs. Again, we'll look at the broad spectrum class drugs that are effective against usually more than one group of bacterium. For example, the broadest spectrum drug that we have are the tetracycline antibiotics. Narrow spectrum drugs will only target specific groups of microbes. For example, polymyxin and especially the natural penicillins are narrow spectrum drugs. So this picture is right out of your text. So I said tetracyclines are one of the broadest spectrum drugs that we have, and this can affect gram negatives, gram positive, the chlamydia, and rickettsia. Whereas tobramycin only affects Mycobacterium, and it's primarily a drug used only against Mycobacterium tuberculosis. Now, some of the penicillins, especially the semi-synthetics and synthetics, will get some gram negatives, but not all, and some will actually be effective against chlamydias. The natural penicillins are only effective against gram-positive bacteria. So let's start with the penicillins. This was the first commercially available antimicrobial. It was, quote, first discovered in 1928 by accident in England by a physician who noticed that he had a friend growing on his Staphylococcus aureus plates, and this friend was causing inhibition of the staph to grow. Well, what he found out this friend was the penicillium mold. Penicillins can be obtained naturally or synthesized in the laboratory. They consist actually of three parts from a chemical standpoint: a thiazolidine ring, the beta-lactam ring, and a variable side chain. And it is this beta-lactam ring that actually allows the penicillins to work against the peptidoglycan in the gram-positive bacteria. So just a few examples. So penicillin G and V are two of the most important naturally occurring penicillins, and they are used to treat gram-positive cocci and some gram-negatives, even though it's very, very limited. Ampicillin, carbapenicillin, amoxicillin have a broader range and are semisynthetic. Methicillin was actually produced because the natural penicillins became, or the Staphylococcus aureus became so resistant to the natural penicillins in the early 50s that we needed another drug that could actually work against these now penicillin G and V resistant Staph aureus. And so methicillin was actually made. The problem is that we also saw resistance to methicillin, and in fact this is where MRSA came in. And so we came up with another drug I'll talk about in a minute to try to treat the MRSAs out there. Now, I will mention clavonic acid by itself is not an antibiotic, but what this drug does is it inhibits beta-lactamase enzymes, also known as penicillinase. The beta-lactamase or penicillinase breaks the beta-lactam ring, effectively stopping the function of the penicillin drugs. When we add clavonic acid to some of these other penicillins, it increases their effectiveness in the presence of penicillinase producing bacteria. And oftentimes it is actually added to amoxicillin to actually create ampicillin. So, just again, some characteristics of the selected penicillin drugs. Penicillin G and V are nice because, again, they're naturally produced by the penicillium mold, so they're low cost, low toxicity, but the problem is they're very narrow spectrum. So some of these other synthetic and semi-synthetics work much better because we've given them more of a chance to work against some of the other bacterium as well. Cephalosporins are very similar in their structure to penicillin in that they have a beta-lactam ring right here. And so anything that would produce penicillinase will also stop the cephalosporins. While penicillin was the first drug that was used in humans, and really this was during World War II, starting in the early 40s, cephalosporins were actually isolated in a natural form from the Cephalosporium mold in the mid-40s. And so they were actually being used along with the penicillin. We are now up into the fifth generation of the cephalosporins, and the fourth and fifth generations pretty much are all going to be synthetically produced. The fifth generation drug is used primarily against MRSA and VRSA, and also against penicillin-resistant gram-positives and gram-negatives. So we actually have all made it all the way from the natural ones in the first generation out here to the fifth generation. Now, some other drugs that are just miscellaneous drugs that target the cell wall are the carbapenemines. And these are very powerful but potentially toxic, and they're really reserved when other drugs are not being effective. The problem with this now is that we've used these against the gram-negative so much because the penicillins and cephalosporins are not as effective against gram-negatives, that we now have carbapine-resistant Enterobacteriaceae. Enterobacteriaceae are a whole group of gram-negatives, including E. coli, salmonella, and others, and so we now have this new resistant group called the CREs. Bacitracin also will target the cell wall, and bacitracin is one of the ingredients found in most of the triple antibiotic ointments that we use topically that you can get over the counter. Isoniazid will target the cell wall of, actually, the acid-fast bacteria. And so this was an old drug used to treat tuberculosis, but the mycobacterium became fairly resistant to it. We stopped using it, and now we've actually gone back to it. And I mentioned that we'd have another drug that came into our purview for the MRSA, and this was actually vancomycin. And so vancomycin was actually made specifically to treat Staphylococcus infections that were resistant to penicillin and methicillin. Problem is, the staph figured it out and have become now resistant to vancomycin. So not only do we have methicillin-resistant Staph aureus, we've got vancomycin-resistant Staph aureus, known as VRSA. And really now, MRSA stands for not methicillin, but multiple resistant Staphylococcus aureus. The aminoglycosides are going to be drugs that work on protein synthesis. They are products of actinomyces bacteria, which are one of our filamentous bacteria, and primarily Streptomyces and the Micromonospora. They're pretty broad in their antimicrobial spectrum, but they are actually potentially very toxic. So, one of the most commonly used aminoglycoside is streptomycin. It's broad spectrum and does a pretty good job, but I will say again, the aminoglycosides are actually very toxic, especially to the kidney. They do work on the 30S subunits, causing misreading of the messenger RNA, leading to abnormal proteins and dysfunction within the bacterial cell. And this is just the structure of one of these aminoglycosides. And this is actually Streptomyces. Again, the aminoglycosides actually disrupt the function of the 30S subunit, causing misreading of the messenger RNA. Tetracyclines, the natural parent compound, has been used for a fairly long time, but we now have a number of synthetic derivatives. They are the broadest spectrum antibiotics that are out on the market today. They do have a number of side effects. Oftentimes, they cause gastrointestinal disruption by changing the normal microbiome of the gut. Early in life, they are deposited into hard tissues that have lots of calcium. That includes both the dentin of the teeth as well as bone. But because they are broad spectrum, they are used oftentimes as a first-line antibiotic. They actually attach to the transfer RNA on the A receptor site and stop further protein synthesis. The glycyclocyclines, these are a newer derivative of tetracyclines. They block the 30S ribosomal subunit, and they are effective against bacteria that have become resistant to the other tetracyclines. And really the only one that we have is tigecycline, and it's effective against those bacteria that are resistant to the regular tetracycline or doxycycline or oxytetracycline. Erythromycins and the lincamides have a macrolide ring. They are fairly broad spectrum, fairly low toxicity, but we do see a lot of sensitivity, allergic sensitivities to the erythromycin. Clindamycin has adverse reactions in the GI tract and pretty much limits its use. Telithromycin is used primarily for respiratory infections suspected to be caused by resistant bacteria. So the macrolids, and this is again the structure here, and this is that macrolid ring right here of erythromycin and the other mycins, and azithromycin, which is the Z-pack, is in this group. They inhibit translation of the subunit during translation. Some miscellaneous drugs then that target protein synthesis, clindamycin and a couple of other ones, and I will mention linezolid, and this is a synthetic drug that inhibits the initiation of protein synthesis and is used primarily to treat antibiotic organisms such as MRSA and VRSA. The sulfonamides or sulfa drugs. These were really the first, quote, modern antimicrobial drug because they are 100% synthetic. They do not originate from bacteria or fungi. And there's several different ones. We talked about the silver sulfadiazine when we were talking about silver, and this is silver in combination with one of the sulfas, and it works really well against very resistant Pseudomonas, and that's why we tend to use it a lot in burn patients. Another combination is the trimethoprim sulfamethoxazole, and this is actually a pretty good combination as well. So, the silver sulfadiazine used to treat burns, eye infections. Trimethoprim with any of the sulfur drugs inhibits the enzymatic step immediately preceding the step inhibited by the sulfonamides, and trimethoprim often is given in conjunction so that it has a synergistic effect. The quinolones or fluoroquinolones have a very high potency. They are fairly broad spectrum. They're readily absorbed from the intestinal tract, so they are good to give orally, but they have some serious side effects. In some patients, we can see seizures or other brain disturbances. The one nice thing about fluoroquinolones as well is they get into highly infected areas that have a lot of pussy exudate. These again inhibit the DNA gyrase so that we cannot unwind it, we cannot form the replication fork, and therefore we stop DNA transcription. This includes ciprofloxacin, levofloxacin, and several of the other ones, and nalidixic acid. The nalidixic acid is one of the first generation fluoroquinolones and is rarely actually used anymore. Ciprofloxacin was the drug that was actually used and is still used to treat anthrax. And another drug that will target DNA or RNA and prevent transcription is rifamycin. This is limited in spectrum because it can't pass through the cell envelope of many gram-negative bacilli. So this is primarily only used to treat gram-positive bacteria and primarily used to treat the mycobacterium infections of tuberculosis and leprosy. Polymyxins are derived from the Bacillus polymyxa, which is a bacterium. Polymyxins are very toxic to the kidney, and so most of the time polymyxins are used as topical antibiotics. And along with bacitracin, this is oftentimes one of the two of the three antibiotics in the triple antibiotic ointments. Daptomycin is another one that's most active against gram-positive bacteria. And so again, these are going to work against that cell membrane and actually stop then the selectivity of the membrane. Now, many infections that we treat are not just one organism, but they are actually biofilm infections. Biofilms are about 1,000 times less sensitive to the same antimicrobials, or at least the same levels of antimicrobials, as a single organism would be. So there is safety in numbers. Oftentimes different phenotypes are expressed by the biofilm bacteria than would be expressed in a single organism. So how do we treat these biofilms? Well, one thing is we try to interrupt the quorum sensing pathways. Why do you brush your teeth hopefully twice a day? What we're trying to do is basically stop the pioneer bacteria from adhering to the surface of the tooth and actually then producing the plaque. We can add DNase to antibiotics, and DNase will actually help break down DNA in certain cells. And we can do pre-treatments. So while we've cultured, let's say, a staphylococcus out of a lesion, we may try to treat with a fairly broad spectrum antibiotic for staphylococcus, but we may want to be keeping in mind that we may have some others. I remember a dog I treated one time that had staph, strep, E. coli, and 2 or 3 other gram-negatives all in the same lesion. There wasn't really a single drug that was going to work anywhere. And so I had to make my best guess based upon what the bacteria I was seeing and hoping that the immune system would take care of the others. Now, what about the antifungals? Well, these are a little more difficult to treat because remember, fungi are eukaryotic cells and therefore present special problems because they are more closely related to human and animal cells. So most antibacterial drugs are ineffective against the fungi. There are a few exceptions. Similarity between the fungal and human cells means that oftentimes the antifungal drugs are not only toxic to the fungi, but will be toxic to the human cells as well. There's 4 major groups currently in use for antifungal use. The polyene antibiotics, which is the one group of antibiotics that works well. The azoles, the echinocandins, which are actually a derivative of marijuana, and alloamines. The macrolide polyenes, and the one in this group is amphotericin B. So while it's related to erythromycin, it actually works best in fungal, not bacterial treatments. It binds to the fungal membrane, causing loss of selective permeability. It can be used to treat skin, mucous membrane lesions caused by Candida albicans, but there's also an injectable form that can actually be used to treat a couple of the systemic fungi that we see. The azoles, these are always in an azole. So ketoconazole, fluconazole, miconazole, and clotrimazole. These actually interfere with sterol synthesis in fungi. And what this does is it decreases the amount of cholesterol and other sterol molecules in the cell membrane, thereby affecting the selective permeability. The echinocandids inhibit the cell wall synthesis, and this actually then targets chitin within the cell wall. And then the alloamines actually inhibit enzymes critical for the ergosterol synthesis, again, that's found in the cell membrane. Antimalarial drugs. Quinine was the principal treatment for hundreds of years for malaria, and it's actually derived from the bark of a particular tree. Because quinine, though, was so deadly, we've replaced it by some other drugs that are semi-synthetic derivatives called chloroquine and primaquine. Chloroquine is the primary treatment for malaria, while primaquine is a prophylactic drug that will hopefully prevent you from getting malaria if bitten by an infected mosquito. Chemotherapeutic agents for other protozoal infections. Metronidazole is an amoebicide. And for the antihelminthic drug therapies, mebendazole and albendazole, and pyrantel and praziquantel, and all of these get different ones of our helminths. Now, antiviral drugs. There are 3 major modes of action for antivirals. Barring penetration of the virus into the host cell, and we call these entrance inhibitors. Blocking the transcription and translation of viral molecules, and these are referred to primarily as protease inhibitors, and prevention of the maturation of viral particles. So there's a number of these antiviral drugs, but remember, these drugs are actually working inside the host cell for the most part. So this becomes a problem. So Couple of our entrance inhibitors here, and you don't have to necessarily remember their names, but I will say Tamiflu is one of these. When should you give Tamiflu? Well, you should actually give Tamiflu within the first 24 hours after exposure to a flu virus. Most of the time, you don't even know you're sick in those first 24 hours. After 48 hours, Tamiflu is basically ineffective because by then the viruses have all entered their host cells and this drug will not be effective. Acyclovir is one of the most widely used antiviral drugs. This actually mimics the purines within the DNA. And so what this will do is actually get into the place of adenine or guanine and stop DNA replication. No DNA replication, we don't make viral proteins. This group down here that also inhibits nucleic acids, zuvitidine, or better known as AZT, and these others actually have been used historically to treat HIV, and they are protease inhibitors that stop viral protein production. Now, I say viral protein production. The problem is they stop all protein productions within the host cells. And then lastly, indinavir and squaninavir, both of these also are protease inhibitors used primarily in the treatment of HIV. So, can you name one antibiotic found in each of the major groups? Drugs that target the cell wall, those that target protein synthesis, those that target metabolic enzyme systems such as folic acid synthesis, and those that drugs that target DNA or RNA replication, and drugs that target cell membranes. True or false? Antifungal and antihelminthic drugs can be toxic to human cells. And true or false? There are as many antiviral drugs as there are antibiotics. Now, let's talk a little bit about drug resistance. How do microbes become resistant to a drug? Well, these are adaptive responses in which the microorganisms begin to tolerate an amount of drug that would normally be inhibitory. This oftentimes is due to genetic versatility and adaptability of the microbial populations. Again, this is really survival of the fittest. Intrinsic versus acquired resistance. Intrinsic resistance is the bacteria have become resistant to antibiotics by products that they produce themselves. And sometimes this is due to simply spontaneous mutation. Acquired is when the bacteria actually acquire the resistance to a drug in which they have been previously sensitized. And oftentimes they're reacquiring this resistance from another bacterium. So, resistance through spontaneous mutation, and again, survival of the fittest. Minimal changes that the mutation will be advantageous, but if it is, then that organism will survive the antibiotic while all the other ones actually die off. There's a smaller chance that the mutation will confer drug resistance, but it has been known to happen. And so what we'll find is that as those resistant organisms survive, they reproduce, and now we get larger and larger percentages of the overall population of a microbe to be resistant to that particular drug. So large microbial populations and consistent rate of mutations ensure that these mutations do occur. Resistance occurs through horizontal transfer. So resistant factors found on plasmids that can be passed through conjugation, or simply pieces of DNA that are taken up by competent bacteria through transformation, or is there a resistant gene that is passed through transduction with the bacteriophage? And transposon drug resistance is actually also seen. We can reproduce or duplicate that resistant gene into a plasmid that then can go from one bacterium to another. So, sharing of these resistance gene accounts for the very rapid proliferation of drug-resistant species. Gene transfers are extremely frequent in microbes in nature. Genes even from unrelated bacteria or viruses and other organisms that live in the body's normal microbiota or environment can be shared very easily. Some bacteria will actually synthesize new enzymes to break down the drug. And so a good example of this was the penicillinase or beta-lactamase. This only occurs, though, when new genes are actually acquired. The permeability or uptake of the drug into the bacteria is either blocked or decreased. And usually this occurs due to, again, an advantageous mutation. Or even though the drug may be taken into the bacteria, they have figured out an elimination system where the drug is immediately eliminated and therefore cannot get to its acquired target. Usually this occurs due to acquisition of new genes from other bacteria. Some bacteria simply reduce the binding sites for the drug. So now we simply don't have enough binding sites on the target of the drug, and therefore it limits its ability to work. An affected metabolic pathway that is shut down may actually be produced by an alternative pathway of some sort. This oftentimes occurs due to mutation of original enzymes or the enzyme or enzymes. So, for example, new enzymes are synthesized in activating the drug, such as penicillinase. If I break that beta-lactam ring in the penicillin or cephalosporins, it no longer is going to be effective against the peptidoglycan in the cell wall. Permeability of or uptake of the drug is decreased or blocked in some way, and so it just simply doesn't get into the cell if it's one of those that works in the cell. Or again, even though it may be taken up, it has a new active drug pump that just simply pumps it back out immediately. Or the binding sites on the target are reduced and therefore the drug cannot bind correctly. Or again, this is the normal enzymatic pathway, but if it gets blocked, we may be able to produce a new or go through an alternative pathway to the same product. Now, any large population of microbes is likely to contain a few individual cells that are just naturally drug resistant, either through usually spontaneous mutation is the way that this is going to happen, or they just simply are resistant. And so there's always going to be in a population of bacterium a few individuals that will be resistant to whatever drug you throw at it. If the drug is not present within the population, the number of these resistance forms will actually remain low because they're not being challenged. If the population, however, is constantly being exposed to this drug, the sensitive individuals will be killed off and the resistant forms remain and reproduce. So let's say that all of these colonies in this population of these two in red are the resistant groups. Everybody else would be sensitive to an antibiotic that would be introduced. But right now there's no antibiotic, so everybody's growing very happily. But if I introduce the antibiotic and then plate this, what I'm going to see is that I kill off all the sensitive ones and the resistant ones then can overgrow, and I'll get a higher increase in the percentage of resistant organisms. So as a population is exposed to the antibiotic, the resistant organisms gradually increase. Offspring of the resistant microbes inherit those drug-resistant genes, and the replacement of the susceptible susceptible population that was killed off by the resistant ones will simply increase the number or percentage of the resistance within the population. Eventually, the population will become completely resistant. So the more fit microbe has survived. Now, what is our role in antimicrobial resistance? Well, we have actually done this to ourselves. 75% of all antimicrobial prescriptions are for pharyngeal, sinus, lung, or upper respiratory infections, the vast majority of which are viral in infection. Antibacterial or antibiotics do not work against viruses. So if you come in, you're sneezing, you're snotting around, you got clear fluid coming out your nose and your eyes, more than likely that's viral. Should we give an antibiotic? The answer is absolutely not. But what do you want when you go to the doctor? You want that magic pill that's going to make you feel better. And so the doctors oftentimes will give you an antibiotic that's not going to do anything for the viral infection, but may actually make some of the bacteria that are present now more resistant simply because they're being exposed to this antibiotic. So the shotgun approach to antimicrobial therapy has really done us in many ways. Tons of excess antimicrobial drugs produced in the US are also exported to other countries for use, and so this is not just a problem in the US. This is a global issue. Also, the hospital factor plays a role. The hospital environment is a continuous exposure of these pathogens to a variety of drugs. I mean, that's where the sick people go. That's where the microbes are. We're using all these antibiotics to treat all these different patients, and now we're actually growing resistant groups of bacteria. So hospitals house susceptible patients with weakened defenses because you're already sick, and so that makes you much more prone to these resistant infections. Also, the fact that the workforce may not strictly adhere to universal precautions and may actually play a role in spreading these resistant organisms from patient to patient. This has led to penicillin resistance in nearly 100% of all the Staphylococcus aureus strains in the last 30 to 40 years. Also, and this is changing by the way, but nearly 80% of all antibiotics in the U.S. were given to livestock in their feed as prophylactic to prevent disease. Now, this has changed within the last 10 years. This has actually has come under scrutiny, and if you want to feed an antibiotic to, let's say, your cattle herd, it must be actually approved through a veterinarian. This has actually caused us to drop the amount of antibiotics used in animal feed and actually is stopping some of that prophylactic use. Allegedly, all of this antibiotic fed to these animals decreased infection and improved animal health and size within the herd, but the fact that then these animals were developing resistant organisms and then these pathogens jump from humans and cause these drug-resistant infections. Well, while this may have played a small role, and I agree it probably did, but I don't think it was the major role in all these microbial resistance we find in humans. It's because human physicians were overusing or incorrectly using antibiotics in the human patient. And then, of course, global transport. The majority of infectious diseases are showing drug resistance in all areas of the world, be it an underdeveloped country or the highly developed industrialized countries. Global travel and globalization of food products, and that includes both plant and animal food products, allow for rapid export of drug resistance. The CDC a few years ago put out a list of several diseases that it is watching. Urgent threat included the CREs, drug-resistant Neisseria gonorrhoeae. Serious threats included multi-drug resistant Acintobacter, drug-resistant Campylobacter, fluconazole-resistant candida, which is a fungus, extended spectrum beta-lactamase producing Enterobacteriaceae, and again, this is gram-negatives, vancomycin-resistant organisms, multi-drug resistant Pseudomonas, and drug-resistant non-typhoid Salmonella. Drug-resistant Salmonella typhi, Shigella, MRSA, drug-resistant Streptococcus pneumoniae, drug-resistant tuberculosis, and concerning threats, and I will say vancomycin has now moved up to the serious threat list, and erythromycin-resistant group A Streptococcus, and so there are others as well that we are now looking at. So this is not just an isolated incident, and here's my theory. The days of antibiotics are done. Unless we find some novel antibiotic that works in a novel way, pretty much antibiotics are finished. Everything is becoming so resistant to all of our drugs, and there are no new drugs that are coming out at this point, even synthetic drugs, that we simply don't have effective antibiotics anymore. So yes, while we still use them, I think that they are becoming much more limited in the way that we're going to be treating bacterial diseases in the future. So some long-term strategies to control drug resistance. Well, restrict the use of first-line antibiotics. One thing that we have found is when we stop using an antibiotic over a fairly long period of time, say a decade, we may then be able to go back to that drug, and it may actually, the bacteria may have actually lost some of the resistance to that drug. Now, oftentimes we see them redevelop the resistance fairly quickly, but we may be able then to shunt around some of these drugs and actually use them more effectively. To enhance surveillance mechanisms, to track foodborne pathogens and pathogenic microbial populations within both animals and humans. This provides up-to-date views of changes in resistant genes within these organisms. Now, the past approach to new antimicrobial therapy was to find new targets in the bacterial cell. I think we've pretty well exhausted all of those at this point. I mean, if we can't affect the cell wall, the cell membrane, RNA, DNA, protein synthesis, or an enzymatic system, I think we're pretty much finished. There's nothing else that we can really affect within the bacterium. So customizing drugs to aim for new targets was really the past approach that we used. The novel approach is now disabling host molecules that the invaders use to enhance their position within the environment. Now, we can sometimes help nature along. Our natural microbiome actually is very good for us in the way that they actually will fight off invaders that are oftentimes the pathogens simply by the fact that they are present in and on us. And so the terms probiotic and prebiotics. Probiotics are actually preparations of living microorganisms fed to animals or humans to improve the intestinal microbiome. This can replace microbes lost during antimicrobial therapy so that we're replacing the ones that we've lost, or can simply enhance the ones that we already have. So example, probiotic yogurt. And typically probiotics are safe, they're effective, and they're very useful in treating certain food allergies as well. And so, yeah, you don't have to eat Activia, but any yogurt that has live cultures is going to be a good source of probiotics. The other thing is that we now actually have probiotic supplements that you can take easily as a pill. Prebiotics are actually nutrients that encourage the growth of beneficial microbes already present in or on the body. And primarily, again, we're talking about the intestinal microbiome. So for example, fructans, which is a sugar, encourages the growth of bifidobacterium in the large intestine, and this actually discourages the growth of certain pathogens. Then we could actually even do replacement, not only with probiotics, but something called fecal transplants. And these have been used primarily for the treatment of recurring Clostridium difficile infections or C. diff infections. Typically with fecal transplants, we will take fecal material from a member of the household that the patient lives in and actually inject, well, I don't want to say inject, but actually place it into the colon to replace the normal microbiome that was present. Why do we oftentimes see C. diff in the patient? It's because we've used broad-spectrum antibiotics that have killed off other members of the normal microbiome and allowed the C. diff to actually overgrow. Usually this is actually done through a colonoscopy so that we seed, if you will, this normal microbiome from the other person into and throughout the large intestine. So, bacteria can be resistant to antibiotics without ever even encountering the drug. True or false? Can you list and describe 5 mechanisms of antibiotic resistance? True or false? The majority of antibiotics are prescribed for humans to treat viral infections. And nearly 80% of all antibiotics, until recently anyway, in the U.S. were given to whom? And blank has been used in Eastern Europe to effectively treat bacterial infections. And this one you may have to do a little research with. So are there side effects to these drugs? And yes, and some of them can actually be very deadly. We can have direct damage to tissue through toxicity of the drug. I mean, these are toxic drugs, and so the closer the cells are to the human host, the more damage to the human host it can cause. We can see allergic reactions, disruption in the balance of the normal microbiome. Drugs most often adversely affect the liver and the kidneys. And again, I said the liver and kidneys are 2 very important organs that will actually biodegrade and excrete these toxic products from the body. And so even though your liver and kidneys may be functioning well, the drugs themselves may actually cause damage to these organs. We certainly see disruption in the gastrointestinal tract. In fact, probably one of the most common side effects of antibiotics is simply diarrhea because we're altering the normal microbiome of the gut. The cardiovascular system and blood-forming tissues, I mentioned chloramphenicol. In 1 out of every 30 to 40,000 patients that receives chloramphenicol, it kills the bone marrow permanently. That's not a good thing. Great, we cured your infection, but now you have chronic anemia. Some can affect the nervous system, like the fluoroquinolones. Some will affect the respiratory tract. Some can affect the skin, the bones, and the teeth, especially the tetracycline that can cause permanent discoloration of the bones and teeth early in life. And this is just a table out of your text that shows some of these damages that can occur from some of these drugs. And again, if you'll notice, diarrhea, diarrhea, uh, vomiting, nausea, headache, seizures, kidney damage, GI distress. So a number of these different different toxicities can be produced. Interestingly enough, I know a lot about the tetracycline because this binds to the enamel of the teeth early in life, actually during prepubescence. And this causes a permanent gray or brown discoloration to the dentin of the teeth. This will also cause the same discoloration to the bones. So because I had tetracycline as a kid, because I had so many infections of tonsillitis, I actually have permanently discolored teeth and bones. Tetracyclines can also cause liver damage, especially during pregnancy, and they can cross the placenta and actually be deposited in the developing tooth buds of the fetal teeth as well as the bone. Diarrhea is probably, again, the most common complaint, that along with vomiting and or nausea associated with oral antimicrobial therapy. For example, I cannot take ampicillin. It makes me sicker than a dog within 10 minutes of taking it. Just cannot take it. It can progress to severe intestinal irritation or colitis and may result in secondary infections such as Clostridium difficile infections. Some drugs directly irritate the intestinal lining and can cause, again, vomiting and or diarrhea. But also, oftentimes, this is simply because we're disrupting the normal microbiome, and this causes then the side effect. Allergy drugs can act as an antigen that stimulates the allergic response. This can be provoked by the intact drug itself or metabolites of the drug as the drug is broken down, or even substances that develop from the body's metabolic alteration of the drug. So here's a nice pretty woman. However, she's allergic to penicillin, and this is what happens if she takes it. Introduction of broad-spectrum antimicrobials oftentimes suppress and alter the normal microbiome. So while we're treating the infection, we're killing off the good guys as well. And so by destroying normal microbiota, even those far removed from the original infection, this can result in secondary, either direct pathogenic infections or oftentimes cause secondary opportunistic infections. So for example, getting a yeast infection in the vagina while you're taking an antibiotic to treat a gastrointestinal infection. Superinfections are where beneficial resident species are destroyed through usually broad-spectrum antibiotic therapy, and the microbes that were once very small in numbers and kept in check by the other normal microbiome that are killed off begin to overgrow and cause disease. And Clostridium difficile is one of these super infections. All of us have a few Clostridium difficile organisms in our gut. It's only when the E. coli and other normal microbiome get killed off that these surviving organisms then begin to overgrow and cause these super infections. So, can you describe the adverse reactions to the following antimicrobials? Tetracycline, sulfonamides, flucytosine, that should be cytosine, chloroquine, and what accounts for the greatest number of drug allergies? And again, you may have to do a little research in that. An overgrowth of certain microbes due to antibiotic therapy is known as what? So that's the antibiotics and other antimicrobials. And again, this is just kind of a quick overview of some of these drugs. If you want to know more about them, or if you will need to know more about them, you will be taking pharmacology. So have a great day.